My name is Judith Edwards. I'm a postgraduate research student at the University of Surrey, and I'm presenting a qualitative systematic review on the barriers and facilitators to implementation of non-medical independent prescribing in UK primary care. This review forms part of my PhD and was undertaken in collaboration with my supervisors, Professor Melaine Coward and Dr. Nicola Carey. Background. As the most common form of healthcare intervention, population growth, ageing, the rising prevalence of long-term conditions and multimorbidity, as well as the recent COVID pandemic, are rapidly driving demand for medicines. At the same time, however, there's a global shortage of 18 million healthcare workers, which is seriously threatening the sustainability and equity of access to primary healthcare. Worldwide, therefore, healthcare systems are attempting to address workforce deficits by upskilling the non-doctor workforce, particularly through implementing advanced practice roles. Independent prescribing, which is the ability to autonomously prescribe medicines without the involvement of a doctor or other prescriber, and which is integral to advanced practice, has been shown to make better use of existing workforce skills, as well as build capacity for sustainable service redesign. In the UK, there are 7 non-medical professions with independent prescribing rights, including nurses, pharmacists, optometrists, and 4 allied health professions. However, as an innovation that introduces new skills and behaviours, and yet requires the involvement of a range of stakeholders and organisational processes and departments, implementation of independent prescribing is recognised to be complex. To date, there have been no published qualitative systematic reviews specifically conducted in UK primary care literature that have synthesised studies on independent prescribing undertaken by all professions. So the aim of this qualitative systematic review was to identify and synthesise barriers and facilitators to independent prescribing in UK primary and community care settings, to explore their influence on adoption, implementation and sustainability of independent prescribing, and also to make recommendations for would-be implementers and practitioners. And the protocol for this review was registered with Prospero in 2019. Methods. 6 international electronic databases were searched using adapted search strings, and this was supplemented by manual reference searching. The search timeframe was January 2010 to September 21. Inclusion criteria included all peer-reviewed primary research that was conducted in the UK in primary or community care settings, studies that were qualitative or mixed methods with qualitative components, studies that had empirical evidence of barriers and or facilitators, and studies undertaken in independent prescribing by legislated non-medical healthcare professionals. So from resultant studies, data was extracted using a bespoke table, and that captured information on context, methodology, barriers and or facilitators and main findings. And the data extraction tool was piloted on 5 index studies. Quality was assessed using the quality assessment tool for studies with diverse designs. And the data was analysed and synthesised using a 4-stage thematic process described by Thomas and Harden, and this was undertaken by 2 independent reviewers. So the results: 23 articles fulfilled the inclusion criteria, 2/3 of which addressed nurse independent prescribing, and fewer studies addressing pharmacist prescribing, and only 1 study conducted in allied health professions. Just under half of studies were undertaken before 2011, and there was a mix across different general practice and community settings. 2/3 of studies were from England, 4 were from Scotland, and 5 were conducted across the devolved UK nations. However, the representation of independent prescribers from Wales and Northern Ireland was limited. The quality assessment The average quality score was 25, which suggests moderate quality. There were 8 higher quality studies, which in general gave richer contextual descriptions, involved implementation theory, and also had a greater focus on implementation and barriers themselves. So the key findings: a large number of barriers and facilitators were identified that were influential at service, team and individual practitioner levels, and which were synthesized into 4 major stages of implementation. A preparation stage, which relates to organizational readiness for implementation. A training stage, which relates to optimizing practitioners for independent prescribing. A transition stage, in which relates to supporting early transition of prescribing into practice, and then a sustainment phase, which relates to maximising and developing independent prescribing roles. We found that many barriers were interdependent. For example, if there was a lack of mentoring relationship between doctors and prescribers, there was limited opportunity for informal support during early transition, which in turn prevented prescribers from developing competence, and which risked loss of confidence and underuse of the qualification. So this slide shows stage-specific recommendations, which suggests that overall there needs to be a more coordinated and cohesive approach to implementation across its entire trajectory, from initial preparation of the organisation to the long-term sustainability and development of independent prescribing roles. Looking, for example, at the preparation stage, ensuring that team services have a clear mandate for how prescribing will fill in gaps in existing medicines pathways. Ensuring that stakeholders collaborate to cement understanding for where and how prescribing fits in, and how team members can fulfill their own supporting roles in implementation, and above all, ensuring that managers fully support implementation across its entire trajectory, so that support doesn't cease after initial funding for training, for example, but continues to the sustainment stage. Prescribers' support needs, for example, their training needs, change and evolve over time, and it's important that leadership is active throughout. So in conclusion, the review identified numerous barriers across 4 key stages of implementation. Many barriers were repetitive across the review decade and were as prevalent today as they were a decade ago. Overall, there needs to be greater literature focus on long-term strategy and sustainability of independent prescribing to ensure it is effective in alleviating workforce shortages and addressing medicine's needs. And as the non-medical prescribing agenda is further disseminated across the UK NHS, for example in the paramedic profession, it's going to be increasingly important to consider the theoretical basis for developing strategies to achieve its successful implementation.